Good morning, everyone. My name is Harjivan, and me with my group, I'm going to present the ventricular fibrillation. So, for the introduction of the ventricular fibrillation, we all know that ventricular fibrillation is a life-threatening cardiac condition that is characterized by a rapid, disorganized electrical activity in the ventricles. Instead of the coordinated contractions, the muscle fibers coordinate and contract in the uncoordinated way that leads to the immediate or a severe loss of the cardiac output because of the ventricles are no longer effectively pumping the blood. So, without any immediate intervention, especially the deep fibrillation, this condition leads to the pulseless cardiac arrest, loss of consciousness, and even death within the minutes. If left untreated, it can cause the irreversible damage to the heart muscles. So, for the quick view, we're going to see a 2D and a 3D video of the cardiac fibrillation. So, first would be the 2D view.
Ventricular fibrillation, also known as VFib, happens when electrical signals in the ventricles become very rapid and chaotic. As a result, the ventricles quiver and are not able to pump blood to the lungs and the rest of the body. VFib can happen during or after a heart attack or in a heart that is damaged from another condition.
So this is a 3D view of the ventricular fibrillation. As we all can see, the heart is like contracted in a very unregulated way. So for the next slides, we're going to discuss about the etiological factors, like what is the cause of the ventricular fibrillation. There are several key causes and the risk factors that can lead to the ventricular fibrillation. First and foremost, it's the acute myocardial infarction, that is also known as the heart attack. When a part of the heart muscles are deprived of the oxygen due to the blocked arteries, electrical instabilities in the ventricles, and so ventricular fibrillation can be developed. So another cause would be the electrical electrolyte imbalance. As we all know, the high or the low potassium level, it can cause a severe dangerous impact on our heart as well as on the body. So for the heart, the high or low potassium level affect how the electrical impulses are conducted in the heart. Additional triggers include the electrical trauma, cardiomyopathies, certain drug overdose, such as digitalis toxicity, or the severe heart failure. So, for the risk factors that include the likelihood of the ventricular fibrillation, include advanced age, structural heart diseases, intrinsic conduction defects such as the bundle branch block or a long QT syndrome. So for the next slide, we're going to discuss about the pathophysiology, like what's happening in the heart. So now let's have a look on the pathophysiology. So for the pathophysiology, in the ventricular fibrillation, the electrical impulses become abnormally fast and erratic. They spread in a disorganized fashion through the ventricles. Instead of a single organized contraction, our heart muscle twitches, and this prevents any effective blood flow out of the heart. This results in an immediate cardiac output to drop to zero, and the patient loses the consciousness within the second. The pulseless cardiac arrest can set in. If not treated within the minutes, ideally through the defibrillation, it can lead to the irreversible damage to the to the heart muscles or the death. So that's why it is very considered as a cardiac emergency. So next slide would be continued by Ranveer.
Good morning, Professor. Now I'm going to discuss about the prevalence of ventricular fibrillation. There is 3 points. First is the ventricular fibrillation as a leading cause. Like fibrillation is the one of the most common cause of sudden cardiac arrest and sudden cardiac death. Then it is especially more common in men and older adults, according to the research. The second point is ventricular fibrillation and out of hospital cardiac arrest. Ventricular fibrillation occurs about 23 to 38% of all out of hospital cardiac arrest, like meaning nearly 1 in 4 and 1 in 3 out of hospital cardiac arrest involved in ventricular fibrillation. The third one is there are about 3 156,000 out of hospital cardiac arrest cases seen in the United States. Many of these like present with ventricular fibrillation, which is life threatening rhythm that must be treated immediately with the defibrillation. So the next slide, please. So we're gonna discuss about the clinical manifestation and contributing factor. So there are so many like causes of this. First is the first is commonly linked with the coronary artery disease and acute myocardial infarction. A myocardial infarction, like ventricular fibrillation, is commonly associated with the CAD and acute heart attack. Ischemia, like lack of blood flow to the heart during or shortly after MI, can also trigger the ventricular fibrillation. Then, then the electrolyte imbalance is also the cause of ventricular fibrillation. uh, like low potassium, hypokalemia, or magnesium hypomagnesia level can also disrupt the heart rhythm and induce the ventricular fibrillation. Then structural heart disease, like we're gonna see some people like there is a cardiomyopathies like weak heart muscle, valvular heart disease, or congenital heart defects also present from the birth, which gonna cause the ventricular fibrillation. Also, there are some drugs which cause ventricular fibrillation, like antiarrhythmic drugs and digoxin toxicity. Then after that is inherited condition like Brugada syndrome. This is a rare but serious condition, like where is a genetic heart condition that affect the way of electrical signal pass through the heart. Then long QT syndrome, which is also these genetic syndrome like affect the heart to electrical system and increase the risk of ventricular fibrillation. And then the next slide, please. So there are other like clinical manifestation and contributing factor that affect the ventricular fibrillation, like sudden collapse or unconsciousness. Like ventricular fibrillation often occur an abrupt loss of consciousness and due to heart's inability to pump the blood. No vital sign, like there is no detectable pulse or no blood pressure in the ventricular fibrillation person. No breathing or agonal gasps. Like victims may not be breathing at all and may exhibit agonal grips, like brief abnormal breathing efforts. Then there is a possible warning sign, like some individual may experience symptom before the ventricular fib onset, like chest pain, heart palpitation, dizziness, and shortness of breath. Then uh, rapid deterioration, like immediate CPR or defibrillation, like it gonna ventricular fibrillation can lead to permanent brain damage or death within a minute. So it's a medical emergency of ventricular fibrillation. Then next slide, please. Now we're gonna discuss the assessment and immediate action in ventricular fibrillation. Firstly, we're gonna check the person is conscious or unconsciousness, absence of pulse, no breathing. These are like hallmark of sign of cardiac arrest. Then we're gonna monitor the ECG. On the ECG, ventricular fibrillation appears as uh, chaotic, irregular, and disorganized electrical activity. And there is no identifiable QRS complex, which indicating the ventricles are not contracting effectively. Then we gonna take the history of the patient, like what is the underlying health condition, like there is any coronary artery disease, and MI, or electrical imbalance like low potassium or magnesium. Then there is an emergency response, like early defibrillation and high quality of CPR are crucial, and time to first shock is a major determinant or survival. Every minute counts. So prompt assessment and recognition of ventricular fibrillation on ECG immediate life-saving intervention like defibrillation and CPR is essential for patient survival. So that's from my side. The next slide will be explained by Shubham.
So, good morning, everyone. So, I will be presenting management strategies and rationale. So, defibrillation and CPR are immediate first line interventions to restore cardiac output. As we all know about VFAB is equals to DFAB, which means that defibrillation and CPR are must. Then, about 100 to 120 should be the compressions rate in the CPR, and 2 to 2.4 inches should be the depth of the chest compressions. So basically we have like CPR rules and regulations in which we have to give 3 to 4 cycles of about 100 compressions, 30 compressions. Then after 30 compressions, we'll give 2 breaths. So the depth should be 2 to 2.4 inches. Early defibrillation will terminate the disorganized rhythm and promote survival with ventricular fibrillation. As we all know that early treatment is must in every disease condition. So same goes with the ventricular fibrillation. If early defib is there, like defib is available in the early stage of VFib, then it is more likely that the patient can survive. So the next we'll have management. The next we have epinephrine, that is 1 gram IV, and 3 to 5 minutes will enhance perfusion and electrical activity. So epinephrine enhances the electrical activity, so it will affect in about 3 to 5 minutes. So then next we have a myodron, which is 300 mg IV, and it can be given after the failure of defibrillation to obtain a rhythm. So after a defib, there is no rhythm, so then we give a myodron. Oxygenation and protection of the airway need early intervention during the code. So as soon as we announce the code blue, so oxygenation is must. So as we all know that ABC, we work according to ABC. So airway is must. Then comes breathing. Then comes the circulation. So constant monitoring avoids delayed response to drug consequences or rhythm change. Then next we have intercollaboration team approach, in which nurses perform CPR, give medications, and change compressors every 2 minutes. So in every 2 minutes, we have to change the person who is giving chest compressions. The main reason is that after 2 minutes, it is considered that we would not give efficient compressions with the same effect. So we have to change the person giving the compressions. So physicians perform defibrillation, rhythm interpretation, and journal called leadership. Then respiratory therapist will give airway support and use bag valve, mask or ET tubes. Then pharmacist will assist in preparing and ensuring timely medication preparation and compatibility in resuscitation process. So this is all inter collaboration team approach. Uh, then next goes Simranjeet.
Hi, good morning, class. Good morning, professor. So, I'm going to discuss about the nursing role in case of acute phase and chronic or long-term case, in case of a ventricular fibrillation. So, first of all, I discuss about the acute phase. So, that as a nurse, it's a role to respond promptly in a emergency condition. So, nurses must quickly assess for the recognize the signs of cardiac arrest. These are no pulse. If we are saying that the patient has no pulse, patient is not responding, and breathing is abnormal, so we should act immediately. Activation of the emergency response, calling for the help, and starting the chest compressions to improve the survival outcome. So the second step we will do is defibrillation support. So early defibrillation is essential in ventricle fibrillation, as Shubham has already discussed that if a patient is having a VFib, so we should go for the DFib. So nurses may use an automated external defibrillator. So we can also use an automated external defibrillator. So What is that? The AED is a portable medical device that detects life-threatening heart rhythms like ventricular fibrillation. So it delivers the electric shock to help the heart return to a normal rhythm. So the other option we can choose is manual defibrillator. So the manual defibrillator is a medical device used by the trained health professionals who get the certification from the certain organization. So a trained health professional provide the electric shock to the heart during the cardiac arrest. So it requires we need to, for this we need to do a ECG. We need to check the ECG reading and choose the energy level and decide when to deliver the shock. So in case of manual defibrillator, this offers more control but needs professional training to use safely and effectively. So the third point is medication administration. So administering emergency medication such as epinephrine, which the role of epinephrine is increase the blood flow to the heart and brain. So they also manage the air. So the other thing need to do is airway maintaining. So by using the bag valve mask, we need to ensure the oxygen during the resuscitation. So the fourth point is monitoring the vitals. So continuous monitoring heart rate, oxygen saturation, blood pressure, level of consciousness will help assess the effectiveness of resuscitation, and we can detect if patient having a deterioration in the condition or is improving. So next slide, please. Next are the nurse's role in case of a patient is having a chronic or long-term care. So what we can do first is monitoring and prevention. So in case of monitoring, so nurse can monitor the patient for reoccurrence of arrhythmias. So if a patient has a life-threatening condition, and so we can, if patient is has a implantable cardioverter defibrillator. So this means like a patient has so implantable cardioverter defibrillator is a small battery powered device that is placed under the skin. So usually it's implanted in the chest so that monitor and help control life threatening arrhythmias. So especially in case of ventricular tachycardia and ventricular fibrillation, so which can lead to a certain cardiac arrest. So this will ensure that safely and avoid electromagnetic interference and that device is functioning properly. So we need to so we did the monitoring and prevention. So we'll educate the patient about how to keep this device in safely. Next is medication adherence. So we'll educate the patient about the use of anti-arrhythmic drugs. So ensure the patient understand and consistently take the prescribed medication. So which will helps to prevent further episodes. So the third is lifestyle modification support. So we will guide the patient in adopting heart healthy habits like a low salt diet, regular physical exercise, and smoking cessation and weight control. So this will reduce the risk of reoccurrence. And last is support recovery. So in this, we encourage the participation of the patient in cardiac rehabilitation programs, which involves like supervised exercise and dietary counseling and emotional support. So recovery also involves reducing the stress and improving the quality of life. Next slide, please. So last, we will evaluate and give education to the patient. So the first is evaluate the cardiac rhythm response. So in this, after the interventions like defib and nurses should assess the ECG to check if patient's heart rhythm has stabilized or whether we need to further give some treatment according to the need of the patient. Next is reassess vital signs and level of consciousness. So ongoing assessment is vital for the patient, and we need to assess for the level of consciousness, which helps to nurse. We can track that patient's recovery and detect if there is any complication, so we can prompt take early interventions. Third is implantable cardioverter defibrillator use and safety. So for this, a patient needs a clear instructions how to live with this, and such as avoiding the areas with the strong magnets. So in case of if patient is going for the MRI scan, so we need to educate the patient about that. So understanding what it feels like when ICD shocks and ensuring the family members they should know that how to give the CPR in case of emergencies. And the last, so symptom recognition. So we will teach patient and family how to recognize the early signs of reoccurrence, the arrhythmia, so such as dizziness, palpitations, chest pain. So they should call the emergency services immediately when needed. And when the last is when to seek a follow-up. So we need to emphasize the importance of regular cardiology follow-up appointments and monitor for any changes in symptom, so which could indicate that patient is having a worsening or reoccurrence. Last slide. So last is a conclusion. So we have all discussed about the ventricle fibrillation is a emergent condition that needs to be need action promptly. So we need to assess for the signs for arrhythmias, and we need to give CPR as soon as possible. And the last option is defibrillation, and nurses should assess for the acute response and long-term care, from saving lives in a moment to supporting recovery for afterward. And throughout the teamwork and preparation and patient education, nurses improve the outcome and empower the patient to manage their conditions. Thank you.
So now we have the case scenario in which there is a 65-year-old male was found collapsed and unresponsive at home by a family member. He had history of type 2 diabetes mellitus, long-standing hypertension, and a recent inferior wall myocardial infarction treated to conservatively 2 weeks prior. On assessment, the patient had no palpable carotid pulse, was apneic, and in cardiac arrest. A family member initiated high quality CPR immediately after calling emergency services. Paramedics arrived within 8 minutes. The initial rhythm on the cardiac monitor was VFib. Two defib attempts were administered using biphasic shock. IV epinephrine 1 mg every 3 to 5 minutes and airway management were initiated in accordance with ACLS protocols. Return of spontaneous circulation was achieved after approximately 12 minutes of resuscitation. The patient was transported to emergency department where continuous ECG monitoring was started to detect any reoccurrence of arrhythmias. 12 lead ECG showed ST elevation in inferior leads and the patient was transferred to urgent coronary angiographic which relieved 100% occlusion in the right coronary artery. A drug eluting stent was successfully placed. He was admitted to ICU for post cardiac arrest care and therapeutic hypothermia was initiated. So the next we have questions related to this.
So for the first question, what is the most likely cause of this patient's sudden cardiac arrest? So any guesses, guys? Okay, so we have the answer. It's C option, ventricular fibrillation due to the myocardial infarction.
Second question is, why is ventricular fibrillation considered a shockable rhythm? Like, anyone know the answer is? The answer is D. It lack organized electrical activity and require immediate defibrillation.
So the next we have, how does early CPR improve survival in cardiac arrest? So the options are maintain brain perfusion, delays defib, decreases oxygen supply, cause arrhythmias. So answer is maintaining the brain perfusion.
So the last question is, when should epinephrine be administered during the ventricular fibrillation cardiac arrest? So the first option is after every defibrillation. Second option is every 1 to 2 minutes. Third is every 3 to 5 minutes, and last is only after ROSA. So the correct answer is every 3 to 5 minutes. So during cardiac arrest, so as we discussed, like 1 mg and epinephrine we need to give IV, and this should be given every 3 to 5 minutes. The work how it works, it causes a vasoconstriction which increase the blood flow to the heart and brain and improve the chances of heart restarting. Thank you, class. These are the references.